49 participants.
Carol, I'll put up the my disclosures, okay? Carol.
Yes, May. Go ahead. You can share. Yeah.
Okay. It's 4 o'clock, right?
3 minutes.
Okay. For those already in, you want to text your friends, remind them to join the Zoom. Because we had 148 registrants. PNAA, those that are already in, you want to text your friends and remind them we're starting in a minute. Okay, it's 4 o'clock. Good afternoon, everybody. My name is May Guzman, and I am the Education Chair for PNAA. And we want to thank you for joining us in this first session of a 4-part series related to COVID-19 pandemic. This series is offered free of charge by PNAA and PNAA Foundation and is dedicated to all nurses in this year of the nurse and the midwife. It is also dedicated to honor our fallen heroes of the healthcare profession here in the US and in our homeland. This session awards 2.1 contact hours. You must be registered at mypnaa.org with a valid email address and must complete the evaluation to receive your contact hours. If you registered with a valid email address, you'll get an email with the heading PNAA support. This allows you to access digital and the evaluation form. You have 15 days from the last session, which is June 6th. Evaluations will close permanently on June 21st, 2020. Our provider of contact hours is the California Board of Nursing. The Philippine Nurse Association of America Foundation is an approved provider of continuing education by the California Board of Registered Nursing, CEP number 14134. My disclosures: the speakers have disclosed no conflict of interest. The purpose of this series is to discuss issues that relate to COVID-19. PNAA and the speakers are not able to comment on an individual's risk factors or medical issues. For medical and personal concerns, please contact your healthcare provider. For current updates, please check coronavirus.gov or your public health department. Zoom instructions. All participants will be muted for the entire session. Only the speaker, the education chair, and the chat monitors have open microphones. All questions must be typed in the chat box at the bottom of your screen. It is best to use the speaker's view located on the top right of your screen. It's a little square with 3 dots on top. The gallery view will show all the participants, and you might not be able to appreciate the lecture. Thank you, and we shall begin. Our speaker is Dr. Francisco C., MD, DrPH. He is a professor and chair, Department of Environmental and Occupational Health at the University of Nevada in Las Vegas, UNLV, School of Public Health from June 2016 to the present. Dr. C. earned his DrPH degree in Immunology and Infectious Diseases in 1984 from Johns Hopkins School of Public Health. Master of Science in Tropical Public Health in 1981 from Harvard School of Public Health. He obtained his medical degree in 1975 and a BS Pre-Med in 1970 from the University of the Philippines. Dr. C is at the National Institute of Health as Senior Extramural Program Director for 12 years, from 2004 to 2016. He worked at the Centers for Disease Control and Prevention, CDC, as a senior health scientist in the Division of HIV/AIDS Prevention for 4 years, from 2000 to 24. In 2003, he led the CDC SARS Community Outreach Team in Asian communities in the US to mitigate the fear and stigma associated with SARS. So we are very proud to have him in our midst today and to deliver this talk on COVID-19 pandemic. Welcome, Dr. C.
Thank you for inviting me. Can you hear me?
Yes.
Okay. You can see from the first slide, my email at the bottom part, my name, francisco.c@unlv.edu. So if you have any question after this, and as a follow-up, if you'd like to email me, my email address is listed there. Next. Next slide. So there are 10 points. I start with the first point. It's a novel virus. When we say novel, it means it's a new virus. There's a new coronavirus called SARS coronavirus 2. So since it's new, that means anyone can get it. And the most common way of getting it is from air droplets. So when somebody sneezes or cough, usually it's about 6 feet away or 2 meters. You can inhale those particles and get infected. Or if somebody sneeze or cough with their hands and then they touch a surface and you touch those surfaces, then you can get infected. So so far, it's found in a large amount of the virus found in the nasal cavity, in the mouth, in the lungs. But the virus has also been isolated, it's also found in the blood, in the stool, and recently also in the semen. But the most common way is really through air droplets. Next slide. So before I go further, I want to talk about why did COVID-19 emerge. So in 1992, the Institute of Medicine convened experts panel to discuss about emerging diseases. So at that time, six factors were mentioned. If you look at the 6 factors, the first one on the top is microbial adaptation and change. The rest are all human behavior, economic development, human demographics and behavior and movement, international travel, technology, industry, breakdown in public health measure. In 2003, they convened again, the same 6 factors emerged. But in addition, if you look at there are 6 additional factors. In the bottom, you can see climate change in the ecosystem, poverty, social inequality, war, lack of political will, and intent to harm. So these are the different factors that cause emergence of disease. And I think for the COVID-19, the international travel play important role because there was a big festival in Wuhan, China in December, and also the Chinese New Year in January. And after that, people went back to their hometown, different parts of the world, and you can see that they transmitted to different parts of the world, including US and Europe. Next slide. The other topic I want to discuss is convergence. So you talk about emergence, what did they emerge? And how about convergence? Convergence means what are the factors that push for the microbe. If you look at the microbe on the right upper corner, the orange square, and if you look at the lower corner, the humans in blue, what drives the human and the microbe to interact? So if you look at that, if you remember your lecture in agent, host, and environment, it's very simple. But nowadays, you look at the convergence model, you look at all the factors surrounding us. Not only if you look at the one on the right upper corner, physical environmental factors play a role. Genetic and biological factors also play a role. And then if you look at the bottom part, social, political, economic factors, and ecological factors. So you can see that all these different factors could converge and push the microbe and human to interact with each other. So in the case of COVID-19, the reservoir hosts are bats. So bats are found in the caves, right? But then there's an intermediate host, most likely another animals that probably consumed by humans, and then eventually it becomes human to human. So basically, coronavirus is a zoonotic infections. It just exists among animal population, but when humans invade those population and humans get infected, they can transmit to other humans. Next slide. So what are the coronavirus? Coronaviruses are very common cause of mild and moderate respiratory infections. And there are 4 types of coronavirus: alpha, beta, gamma, and delta, okay? And as I mentioned earlier, it's a zoonotic infection found in animals. Next slide. Next, yeah. And you can see that it's called coronavirus because if you look at the surface of the virus, they have spikes. Those spikes are called glycoproteins. It looked like a crown, so it's called corona. But they use those spikes to attach to the cell and invade the cell. It's a very important component. And then when they do the test nowadays, the PCR test, they look for those particles within this organism. It could be part of the spike, or it could be part of the RNA that are being used to detect in the PCR test. So this is the coronavirus. Next slide. So there are human coronaviruses have been detected since 1960s. And there are two groups that infect humans, the alpha and the beta. The alpha coronavirus, those cause very minor colds. So they don't really cause epidemic. So they're very common. The important thing to remember is that they can also uh, uh, elicit antibody response, but they're very minor colds. But we're more concerned with beta coronavirus. So there are 5 types of beta coronavirus now, OC43, HKU1, but they don't cause a lot of problem. The problem we have encountered are, the first one is SARS-CoV-1. This one that caused severe acute respiratory syndrome in 2003. And then the other one is MERS-CoV. It's the one that causes Middle East respiratory syndrome, which started in 2012. It's still going on in the Middle East. And then the one that occurred in December 2019 that causes COVID-19 is the SARS-CoV-2. So this is so we have experience already with SARS-CoV-1, with SARS in 2003, and then the MERS-CoV in 2012, which is going on, and then now the new one is called the SARS coronavirus 2 that causes COVID-19. Next slide. So most of us around in 2003 remember the SARS epidemic and the fear about it. So when it occurred, I was working at CDC, and then I remember February 2003, the CDC director sent an email to all of us saying, if you know Chinese language, you know anything about infectious disease, if you would like you to volunteer to join the outbreak investigation team. So I joined, and in 2 minutes they asked me and said, Dr. C, where do you want to go? China, Hong Kong, Vietnam? Because at that time, SARS only occurred in Asia. But I was more concerned with the fear and stigma with SARS. All the Chinatown businesses went down in 2003. People were afraid of Chinese. So I thought it's better for me to just stay in the US and work with different Asian communities. And that's what we did. Next slide. So I formed a group to work with me, and we would go to different Asian communities, and all the Chinatown from Boston all the way to Auckland to LA to, we went everywhere. And then after each of my presentation, they would, in the Chinese paper, they would say, oh, CDC doctor said SARS is not a Chinese disease. At that time, people who get it are mostly who travel to China and return back to the US. So there's no local transmission, human to human. Most of those who got it have history of traveling to Hong Kong or China. But the fear, since people watch their TV, especially they were afraid of it. They think that it's here, but actually it's more common among travelers, but not really. There's no human to human transmission within the US at the time. Next slide. So this is the life cycle. If you look at the left upper corner, I mentioned earlier about the virus with all the spikes. So you can see all those spikes, the crown, like the corona, that those spikes are needed. You can see that they attach to the surface of the cell and eventually invade the cell. And then once they're inside the cell, they'll multiply. And then once they multiply, they produce, to the right upper corner, you can see more virus will come out of the cell. So the virus, the cell, the respiratory cell would be like a factory for them to produce more viruses. So you can see that the viral load is very, very high among this patient. Next slide. And this is the emergence of SARS. If you look on the left side is the MERS. So you can see that on the left upper corner, you can see at 9 o'clock, the bats. Those are the reservoir hosts. As long as the reservoirs exist, we're gonna expect to find coronavirus again, in the future. So you can see that the main reservoir host where they stay is the bat, and somehow the bat would infect the camels. You can see the camels in the middle. And then there's a transmission to camel, and then from camel to humans. So the camel is the intermediate host here, and the bats are the reservoir host. And once they infect the humans, it becomes a human-to-human transmission. So on the top, though, you can see for SARS, the civet, the palm civet, or it's a cat-like animal, is the intermediate host. So from the bats, it goes to the civet, and then civet then infect humans, and then human-to-human transmission occur. So we don't know yet with COVID-19, you know, it's a SARS-CoV-2 that came from the bats. And then we don't know which animal that got infected that transmitted to humans. But right now it's human-to-human transmission that's spreading it. Next slide. So my second point is easy come, easy go. You know, it's one of the movies by Elvis Presley a long time ago. In other words, it's easy to acquire and very easy to spread, especially in crowded areas. The bigger problem really is the asymptomatic carrier who are infected but have no signs and symptoms. That's why in the absence of testing, in the absence of treatment, most countries then adopted the measure of lockdown. In other words, you avoid exposure. You want to prevent negative people from being infected by positive people. So, and that's why you're wearing masks, so that you protect you're protecting other people from you if you are infected, because you may be infected but you don't know it because you have no signs and symptoms. Next slide. So this incubation period, so it's the time from the time you get exposed to the time you show signs and symptoms. So the incubation period for SARS-CoV-2 or COVID-19 is about 2 to 14 days. That's why they will quarantine you. If you're positive, they quarantine you for 14 days. But usually the median time is about within 5 days, you're gonna show signs and symptoms. So 50% people become ill in 5 days. But there's some people that stay as asymptomatic. We don't know how long they stay asymptomatic, and they're infectious to other people. Next slide. So as I mentioned earlier, the most common way of transmission of COVID-19 is through respiratory droplets. So when somebody's cough or sneeze, and you inhale those droplets, you can get infected. But remember, they, because of gravity, they will fall down to the floor or to any objects on the floor. Or if you touch your hand and then touch something else, fomite means inanimate object. So it could be spread by inanimate objects. They could stay in plastic for as long as 72 hours. They can stay in metals for maybe 4 or 5 hours. They can linger on the air maybe for a few hours, but eventually they'll drop down, and eventually if they're on the surface, they will die because they will not multiply on the surface of the any surface. And all you have to do, make sure that you hand washing with soap and water or sanitizer with alcohol are very important. The most important, I think, is really soap and water, because if you look at the wall of the virus, it's made of lipid layer. And then if you have soap and water, the soap and water can destroy the cell membrane of the virus. So the second point here is that asymptomatic are shedding the virus. So most people that are infected may not even know they're infected because they have no symptoms. And usually shedding occur before they have symptoms. We don't know yet how widespread, how long would these people stay asymptomatic. If you look at the last bottom there, you can see stool. You can find coronavirus in the stool, but we're not sure yet if there's an oral fecal route. So the most common way is really through the respiratory droplets. Next slide. So this is a recent study reported in JAMA, May 7, among patients in China. So they look at 28 male patients, and then they studied them, and they found out that the virus are found in the semen, and even in the acute phase, and even in later stages, they showed virus in the semen. So we're not sure what this means. You know, could this be sexually transmitted? Especially if you're in lockdown and they're asymptomatic and you have sex with your partner, could it be transmitted that way? We don't know yet because again, we only have 5 months experience with this virus. So we're still learning more about the virus, but this is something that came up from China, from 28 patients that they followed, only 6 patients showed viruses in their semen. So the question mark there is that just like in the stool, would this cause, would this transmit disease or not? So we're not sure, but again, I want to stress that the most common way is through the respiratory air. Next slide. So the third point is that we are only seeing the tip of the iceberg. If you look at the picture on the right upper corner, you know, on the surface, you see the tip of the iceberg. Those are the cases and the death. But underneath that, 80% of the people have mild infections or no symptoms. So that's a big problem because the asymptomatic are the one spreading the disease to other people. And also the tip of the iceberg only show those people who are severe acute infection, especially the elderly, cause death among the elderly, especially. And our report shows that minorities are getting it in the US because a lot of minorities suffer from underlying chronic disease like diabetes, hypertension, and heart disease and cancer. Because of those underlying illnesses, then they're very high risk for severe outcome like death. Next slide. So what are the signs and symptoms of COVID-19? As I mentioned earlier, if you look at the left side, most people don't have any symptoms, so they're asymptomatic. And most people have mild infection, 80% mild. You know, even though that you got infected, if you got a cold or something and you just ignore it. But then if you look at the right upper column here, you can see the more common signs and symptoms are fever, fatigue, chills, muscle pain, cough, loss of taste, and loss of smell, difficulty breathing, headache, and sore throat. Again, they're non-specific. They may look like flu, right? So you have to be careful in making a diagnosis. Next slide. So what are the severe signs and symptoms? If the fever is persistent and the person's having difficulty in breathing, those are signs that the disease is progressing already. And if you look at the right right column, you can see that if people have these signs and symptoms like bluish lips or face, that means they're having a hard time getting oxygen, increased rate of breathing, shortness of breath, chest pain, waking up in the middle of the night because they couldn't breathe, confusion. All of these things are signs that the person is getting worse, so they need to be brought to the ER and be hospitalized. Next slide. So the risk factors for those who get severe disease are older people, more than 65 years old, people who are obese, people who have chronic illness, but also nowadays there's a report of young people also and healthy people can get it. Although they're small in numbers. And again, children again also can get infected. But again, they recover quickly and they have mild infection. But in recent weeks, we heard about children having multi-system inflammatory syndrome, like the Kawasaki-like disease. But they're still rare. Most of them still recover and have mild infection. The people that really at higher risk are the older people. Next slide. And then older people with the following chronic diseases: diabetes, hypertension, asthma, emphysema, COPD, heart disease, liver, kidney, weakened immune system, like cancer, or patients under immunosuppressive therapy or steroid. Next slide. So risk factors for death really is the lack of oxygen in their body. So that's why they would need ventilator so they can breathe. So death is very rare in young and young adult and children, but it's more common among elderly. As the older one, the rate is higher. So for those above 85 years old, about more than 10% death rate. This based on studies in China. So you can see that the elderly is highest risk. The fourth point is it's fast and furious. In 5 months, it spread to 188 countries. As of this morning, when I look at the statistics, there are now 4.5 million cases around the world, 309,000 deaths, so 5% mortality rate. And in the US, 1.4 million with 87,000 deaths. In the Philippines, we have 12,000 cases, about 817 deaths. But it's hard to compare countries based on that because there are countries with larger population like China and US, and a smaller population like a lot of European countries. So it's better to calculate them as case fatality ratio. That means the number of cases divided by the population, total population in the country multiplied by 100,000. So if you use that as a ratio, you can see Belgium become have the highest fatality ratio. It's a smaller country with a lot of cases. So their case fatality ratio is 76.2. US fatality ratio would be 24.6. Philippines would go down to 0.68 per 100,000. China, with so many billion population, the ratio is only 0.33. The smallest really is in Taiwan with 0.03. Next slide. Now I want to talk about sensitivity and specificity of a test. So this is just like a review for most of you because nowadays you heard so much news about false positive, false negative. What do they mean? So when we talk about sensitivity, we're referring to the probability that the test will indicate disease among those with the disease. So if you look at the table on the right side, look at the second column under disease. You have A, these are people who are truly positive, and C, people who are false negative. They have the disease, but the test says false negative. But if you add these two, these are the people that truly have the disease. So when you talk about sensitivity, you're referring to those true positive, that's A, and the denominator would be the A plus C, those true positive and the false negative. So that's the sensitivity. And the specificity is a fraction of those without disease who will have a negative test result. So that means you look at the third column, that would be D, the truly negative people among those that don't have the disease. That means you have to add B and D. So the formula is on. So the problem that, so sensitivity and specificity are characteristic of the test, okay? So nowadays you can see that the tests that we have in the market, the PCR tests that are used, the sensitivity, there's a lot of false negative result with them. That means the person already have the disease, but it shows as false negative. I think it ranged from 15% to as high as 48%. The Abbott test, that the most recent test they're using, has a false negative, the sensitivity is on the, I think 48% false negative. So for example, the press secretary of Mike Pence was tested on the Thursday. I think apparently in the White House, they test them every day. She was negative. And the following day, Friday, she became positive. So probably she was a false negative. And then when you repeat the test, she became a true positive. So, so far, if you have the test done at CDC, the CDC tests are more sensitive and more specific. So, so you need to remember about this test that, for example, with the antibody test that's available, the problem there would be false positive. Because remember, the antibody, we talk about there are 4 types of coronaviruses, and I mentioned to you some of the coronaviruses that causes minor infection. So those can cross-react and cause antibody to occur in the person. So when you saw a positive test in the antibody, you're not sure if that's really the COVID-19 virus or not. So that you need to really use a more specific test. Next slide. Or you can look at the predictive value of a test, and that means you're looking at the horizontal column. What is the chance that a person with positive test truly have the disease? That would be A. If you the true positive, you add it with the false positive and multiply by 100. So that's that's a positive. These are people who are all positive, and the other one is the negative predictive value. Is the C those true negative plus the false negative plus a true negative, that will give you predictive value. And this predictive value are influenced by the prevalence of the disease. So in other words, if you test in a high prevalence area, then it's more likely that your positive is really true positive. But if you go to another place where the prevalence is very low, then then the predictive value is lower. So so sometimes, but I think in clinical practice, you tend to use more sensitivity and specificity, but some people also look at predictive value. So I'd like for you to be aware that there's this, the way to calculate it. Next slide. So this is a very important slide. So if you look at the left side, starting from the left side, you can see the structure of the SARS-CoV virus 2 there. The first 2 weeks, the person is infected already, but the person has no signs and symptoms. So they're spreading the virus to other people. So if you get tested that time, most likely get a false negative because you don't have antigen, you don't have antibody yet, right? So if you look at the blue line, if you look at the bottom part, it says blue line is PCR from the nasopharyngeal swab. So if you swab through the nose, you can detect it as early as first week of the infection. And that PCR test could be positive all the way until 6 weeks, but then it's higher during the first 2 or 3 weeks. But as you go to 4th, 5th, and 6th week, it's less sensitive because it's harder to find a positive. So the PCR tests that you use through your nasal swab are very good during the first few weeks of infection, from first week to about 3 weeks of infection. The second one is the pink. The pink one is from bronchoalveolar lavage or sputum. You can also collect sputum and do a PCR test and look for the virus. It's also very sensitive during the acute phase of the infection. The virus isolation from the respiratory tract is a red one. You can see it goes up and down right away. It's good only in the first week. So in other words, the timing of when you test the patient and also where you get the sample are important factor for you to find a positive test. And then later on, then you can see you can do antibody tests. So antibody tests are the purple one. The dotted purple one is the IgM. So early on, the first antibody that show would be the IgM, the purple one, the dotted one that goes up and down from the 2nd week to the 6th week. But the other one is the IgG. IgG is the green one, this dotted one. You can see it's also started around 2nd week, but stay longer. You can see the antibody can stay longer, so it's more specific than the IgG antibody. So you can see here that early infection, then you may not find the virus. So if you get tested, it could be a false negative. So that's why in the first few weeks of infection, it's better to use a PCR test, the antigen test, and you can find positive that way. And then, but as a person recover and become in the convalescent phase, and persons start to recover from the illness, the PCR test become less sensitive, and by that time you can do the antibody test. So the antibody test will be positive, the purple one and the green line. Next slide. So you can see here that initially all testing are done at CDC, but it takes time. You have to send a sample from the health department to CDC, and they cannot really test million cases. So that's why FDA allowed other laboratories to do it, like Quest or LabCorp can do it. And then, so there's a lot of other tests available that were authorized by FDA under the Emergency Use Authorization Act. But the problem is that there's so many testing kits out there, and none of them are validated. So some of them can give you false negative or false positive results. So it's better to still go to the health department, because the health department, they do it in their health department, but they also send it to CDC for confirmation. So the health department testing is much better than the commercial one. So you can see here that PCR is sensitive, but again, the sensitivity differ depending on the company, and also depending on the sample. When you swab the patient, you have to go all the way to the back of the nasal cavity. If you just get it sample from the front, you won't be able to get enough sample. You have to go all the way to the back. Next slide. And the antibody test is called serological test because you get blood. You need to look for the antibody in the blood. And again, there are different tests available out there, and some of them are from China and other places, so their sensitivity and specificity are not really well established. So you can see that they range from 85% sensitive, or so it's really again, there could be a chance that's false positive too. So again, you need to repeat. In other words, one test doesn't mean anything. You need to repeat the test. Also, probably you're really negative, but then later on you got exposed, right? So that's why you need to have yourself tested again. Next slide. So my fifth point is the good, the bad, and the ugly. Remember the movie by Clint Eastwood? The good thing is that now they're, they recognize that the heroes are really the doctors and nurses like you and other healthcare workers and first responders who are the heroes in this pandemic, taking care of all the patients. But then the bad thing is that the outcome on this first responders, in a study done by CDC last April, they showed that there are 9,282 healthcare professionals who get infected with COVID-19. 73% of them are female, most likely they're nurses, and 55% of them got it from healthcare exposure in the workplace. But you can see the good news there is that 90% of them were not hospitalized because they got the mild infection, but about 27 of them died. Okay. So the ugly part of it is the racism, discrimination, the hate crimes experienced by Chinese and Asian Americans. So some Filipinos like us that look Chinese, we're also affected by that. So we're being blamed for spreading the Chinese virus that came from Wuhan, China. And next slide.
Inano ko lang yung itsura ko dyan. Pero Tracy is in. So sinabi ko na nandito ka na.
I can hear you.
So kami nagmask nung mag-negative ako and the house.
I can hear you. So, okay, my next slide is about PPE. This is the PPE used in the mid-15th century during the outbreak of the bubonic plague. So you can see that they dress up too, like what we're doing now. Next slide. And this was the PPE that was developed during the Ebola outbreak a few years ago. You can see this is how they use it. And actually, Johns Hopkins also developed the right one on the right side, but I don't I think they're quite expensive, but you can see that it's not like the one being used now in the hospital, because this is a really very secure PPE. Next slide. And this is an article that came out May 3, talking about the impact of the COVID-19 on Filipino healthcare workers. It says here that 1 in every 4 Filipinos in New York and New Jersey are employed by the healthcare industry. And by the time they reported this first week of May, they said that at least 30 workers have died from COVID-19, and many of their family members are also affected by this coronavirus. Next slide. So this slide shows you that as coronavirus spreads, so does anti-Chinese sentiment. Like the one on the left is in South Korea. They're banning the Chinese visitors. This is early in February and March. And then the right one is a nail shop in Vietnam saying, sorry, we don't accept Chinese customers. Next slide. So flattening of the curve. So you hear this term all the time. So if you look at the right side, you can see the red curve, that's the epidemiologic curve, without any protective measure, without social distancing, without the stay home, without all the contact tracing, without isolation. That's a typical epidemic curve. A lot of people suddenly get infected. Eventually, once everybody's infected, the epidemic will die down. But then we did all these different social distancing and mask wearing and also lockdown. We're trying to flatten the curve, the blue side. You can see the blue curve, and that's what's happening now. So the goal there is to slow the spread of the virus, and then the goal is to decrease transmission, so the negative and positive are not interacting with each other, and then you don't overwhelm the healthcare system. Otherwise, the ER and ICU will be filled with COVID patients. So there's sign now that there's really flattening of the curve in US and other parts of the world. Next slide. There's no single magic bullet. The right picture, there's a cover of a book that says no magic bullet. It's about sexually transmitted disease control. So right now there's no cure and there's no vaccine. And I have a feeling that it'll take a long, long time before I can find this vaccine or cure. In the meantime, we've shown that combined interventions work. If you test people and isolate them and do contact tracing and do self-quarantine and improve your infection control practices at home and in the hospital setting, simply washing hands with soap and water and social distance, all of this work together. And we have proven that that's true. So this is what Taiwan and Hong Kong and Singapore did. Look at Taiwan. Taiwan have only 440 cases and 7 deaths. Hong Kong have 1,000 cases and 4 deaths. Singapore have 24,000 cases and 21 deaths. But these 3 countries were affected by SARS in 2003. So when they learned that in January, when they heard about the cases coming from Wuhan, China, immediately they start border control. They want they ban visitors coming in, and if they come in, they would quarantine them for 14 days, and then they would, if they test them, if they're positive, they trace all their contacts. So they did all of this, and they're able to really look at the number of cases. 7 deaths, 4 deaths in Hong Kong, Taiwan. You can see that they're able to show that this is working. Next slide. And also we learned that from our experience with SARS. So SARS occurred in November 2002 in Guangdong, China. And then in 8 months, by July 2003, we're able to contain it. So you can see that transmission, with SARS-CoV-1, which is SARS, is among close contact. And then by doing those combinations that we talk about, we're able to really control the spread of SARS. So you can see the third to the last bullet, infection control was the primary public health intervention used in containing SARS. And isolation of patients was done. Next slide. So there's no treatment for COVID-19. So, you heard so many stories about hydroxychloroquine or azithromycin or remdesivir or this thing. They're all still under clinical trials. So there's no specific drug yet that cure COVID-19. So right now, it's just trying to treat the symptoms. And so most patients that have severe infection then require mechanical ventilation through ventilator. So it can help them in breathing. Next slide. So most of the time you're doing supportive care, like oxygen. Also, they found that prone positioning. So if you, instead of lying face up like that, you do prone, more downward, then it will help patient, especially if they're under intubation or ventilation. Next slide. So there are lots of studies going on for the antivirals, but again, we don't have any good candidate yet, but studies are going on. Next slide. So I want to compare the 4 pandemics. So I mentioned about SARS. In 8 months, we're able to contain SARS. It spread to about 29 countries. But SARS, the total cases was only about 8,000 and about 774 deaths. So mortality rate is about 10%. MERS started in 2012, so going on now. It only spread to about 27 countries, and they have 24,994 cases. And you can see the mortality rate is about 34%. It's much higher. The other pandemic is HIV/AIDS. It started in 1980, infected 75 million people, and 30 million people have died. 40% have died from AIDS. Before we have the antiretroviral, nowadays you don't hear about it because now you have drugs that suppress the multiplication of virus, but it's not a cure. But it's AIDS changed from acute disease to a chronic disease that's manageable, and they're going back to work. And nowadays they even have pre-exposure prophylaxis or PrEP. They can take medication that will prevent them from getting infected. So, and then COVID-19, you can see 4.5 million cases, 300,000 deaths. So what's the future for COVID? Would it look more like SARS, or we're able to contain it? Or would it be more like MERS, where it's going on, continuing on infecting people? Or would it look like HIV/AIDS, that you find a medication, but it can suppress it, but it's just, but no cure yet. So we don't know which pathway COVID-19 would take. Next slide. This is just a long list of different pandemics, from smallpox to bubonic plague to Spanish flu, that affected people for a long period of time. But you can see that in the end, all this epidemic will eventually end, right? So there would be an endpoint also for COVID-19. Next slide. So the common question now is, when will lockdown end? Now you can see that this weekend people are opening up already their city and their state. Or will life return back to normal? What's a double trouble ahead? So the advice to follow the federal state guideline, and the opening should be more gradual and in phases. And CDC recommend that you should see 14 days of decline in cases or decline in death or hospitalization to show that the cases are going down. But you have to make sure that you have testing available. You can isolate, contact tracing, so still need to continue social distancing, wearing masks, and frequent hand washing. Actually, WHO has 6 criteria when to lift the lockdown. One is making sure the transmission under control. And I don't think it's under control in the US yet, but they're already lifting the restrictions. So the fear now is that there will be a resurgence of cases. You should be able to test, isolate, and treat every case and do contact tracing. And then make sure that you immunize the hotspot. In the US, the hotspot now are nursing homes. Nursing home, meatpacking industry, prisons. These are different places where people are testing positive. Making sure that when you open up, making sure that schools and workplace should have preventive measures available. Make sure that you're able to manage imported cases. And also, the most important thing really is what we're doing now. Fully educate your community and empower them. Otherwise, they'll be so afraid. Make sure that they're aware how to prevent getting it and how to prevent transmission. And right now, we're concerned about resurgent cases. So when I say double trouble, I'm saying by fall, you might face both flu and COVID-19. So my advice is that once flu shots available, make sure you get your flu shots so that if you develop flu-like symptoms, most likely that's due to COVID-19, not flu. Otherwise, you get confused whether what you got is flu or COVID-19. Next slide. So my ninth point is each one teach one. Empower yourself, educate yourself, your family, your friends, and most important thing, keep your faith strong. Long time ago, there's another person who had a crown, a crown of thorn, right? And he died for us. And so now we're faced with another virus at the crown. So hopefully, God will be with us and we'll be able to overcome this pandemic. So check this following website. So I use the Johns Hopkins Coronavirus Resource Center for statistics and trends. And then I check the cdc.gov website for prevention guideline. And I check the nih.gov website for treatment and vaccine development. And for global situation, I look at WHO.international website. My last point, next slide, is we're all on this together. An outbreak anywhere in the world is an outbreak everywhere. And we must all work together to prevent and control COVID-19 because we are the world, like the song in 1985, we are the world, we are the children, And then the last one is that, and this too shall pass. Thank you.
The monitors will be unmuted now and they'll take turns asking questions, Dr. C. Thank you so much for the presentation.
You're welcome.
I took a lot of points from your presentation. Well done. Thank you, sir.
Thank you.
Okay, Dr. C, the first question is, what is the brand of, this is Manny, what's the brand of the test for COVID-19 that is being used at the CDC that is more accurate?
No, the CDC developed their own testing. So there's no, CDC have their own testing that they develop. So the health department would do their testing, but then the health department will send their sample to CDC for confirmation. So if you go to the CDC website, you can see they describe their test. I think it's about 99% sensitive and about 96% specific. So I would prefer, if I have a test done, I would prefer that they send it to CDC. But they're not using a commercial one. But since the CDC test is, they cannot handle a lot of tests, then FDA have to approve all these different commercial ones. But the commercially available kit have different level of sensitivity and specificity. So you need to repeat the test to be sure it's really truly negative or truly positive. You have to repeat the test.
Thank you, Dr. C. Go ahead, Emerson.
Thank you, Dr. C. This is Emerson. There's a question from the chat. If you can comment on happy hypoxemics.
Can you repeat the question?
Can you please comment on happy hypoxemics? I think it's the phenomenon about people who are very hypoxemic, but are not symptomatic with really severe shortness of breath.
Unfortunately, I'm an epidemiologist, so I'm not a clinician, so I don't see patients. So I study epidemics, I study the different disease conditions, but I don't handle patients. So I think it's better to refer to somebody in your future speakers who actually see patients. So right now I'm locked down, I'm staying at home, I'm teleworking from home. So I don't do clinical work, so I cannot answer your question, but probably your future speaker probably will be able to answer your question better.
Thank you, Dr. C.
We have the third question, Dr. C. It asks, if about 80% are asymptomatic and a healthcare worker with full PPE care of the patient who tested positive with COVID, is there any chance of infection without knowing it? And would they be spreading it to others unknowingly?
I think that's what's happening. 80% of people are asymptomatic or have mild infection. So that's what's happening. That's why it spread like wildfire. People are infected, but they don't know it because they have no symptoms. So that's why we're asking people to wear masks. It's not really to protect themselves, it's to protect other people. So when they talk or sneeze or cough, the virus will not be spreading around. That's why we did lockdown, stay home, to make sure that the infected people don't mix with other uninfected people. So right now, like in the early part of epidemic, like in February, March, we have more doctors who died because, or nurses, because they're not aware of the transmission. Now with the PPE, I think less contact with the virus. So um, I, I think that using PPE will be good, but I think the problem is the lack of PPE. So it's better to be protected because you have to treat each person as if they're infected. Even day to day when you go out, make sure you have to wear masks because to protect other people from you and from you from other people. So it's really hard to tell by looking at person because they're asymptomatic and they're carrying virus, and we don't know how long this asymptomatic carrier would stay positive with viruses.
Thank you, Dr. C.
The next question, Dr. C, is about how do we reopen the economy? There's a question about how unreliable and how unregulated test kits are. So maybe you could comment on that.
So in other words, it's when you open our economy or going back to work, it's not like turning your light on and off, like switch sudden opening. It's more like when you take a shower in the morning, you gradually open your water and wait for the warm water to come. So it's more gradual, and then you test it, and then, but make sure that when you start to open up, return to work, make sure that you go in phases. So make sure that also give people that are in high risk, in our university, we call them the vulnerable population. So the vulnerable population should have the option of teleworking or not coming to work and stay home and work, and making sure you have all the sanitary supplies available to them at work, and testing should be available so that you can test who's positive, who's negative, and the positive one, you should be able to isolate them or ask them to stay home for quarantine for 2 weeks, and then trace all their contacts. That's the only way you can control this epidemic. And continue our social distancing, continue wearing masks. So in other words, I think eventually that's the new normal. We have to really the typical Filipino culture where you do mano and you hug each other will have to change because unknowingly, the young kids might be bringing home viruses that infect their grandmother or grandfather because of the way we socialize with each other. So we have to really provide social distancing and to avoid transmitting the infections.
The next question, Dr. C, is if an individual tested positive for COVID IgG, will they still need the vaccine once it becomes available?
The answer is we don't know because when you positive for IgG means you have been exposed. And right now we don't know if your immunity is lifelong or not. Unlike when we were kids, we got chickenpox, mumps, rubella, and with those viral infection, you have a lifelong immunity. But look at flu. We don't have a lifelong immunity with flu. Every year we need the new flu shots because with flu, what's happening is influenza virus undergo antigenic drift and antigenic shift. So every year we have to predict what's a new strain of influenza coming, and based on the prediction, the scientists develop a new vaccine. That's why you keep on getting new injection every year for the flu shots. Probably the same thing is happening with COVID-19, because it looked like the first strain that came out from Wuhan, China, and went to Europe, and then the one from Europe went to New York and New Jersey. So there's a slight change in mutation of the virus. And then the Wuhan strain that went to California and to Seattle, again, look a little bit different. There's a minor reassortment of the genes. So we don't know what will happen to the vaccine in the future. Will it be, if the virus keep on changing, then you might have to look at the flu model as an example. You might have to develop a new vaccine every year to predict which strain is going to predominate in this season. So in other words, there's a possibility that it becomes seasonal, just like flu, it becomes seasonal type of viral infection. So the answer to the question is that we don't know whether it's a lifelong immunity or a short-term immunity. We have only 5 months experience with it. We need to follow up a group of patients to see what happened to them.
Thank you, Dr. C.
Yeah, there is a quick question here, Dr. C, about contact tracing. Can you talk a little bit about that?
Yeah, contact tracing actually is a public health measure. We've been using that for STD, we use that for HIV. So in the early 1980s, when we don't have cell phone yet, we do a lot of contact tracing for HIV/AIDS. So the health department actually have people hired called DIS, Disease Intervention Specialists. Their job is really to trace contacts of a case of a disease. And in the old days with the HIV/AIDS, people who get infected actually would tell them, well, I went to a bar and I met X, Y, and Z. I really don't know. At that time in the 80s, we don't have cell phone, but they would say, I know Mr. X, but I don't know the last name. So the contact person, contact tracer person would go to that bar and look for the person to fit that description and tell them, I think probably you've been infected, so we'd like you to come to the health department for testing. So that's in the good old days, you know, when you have to do that in person. Nowadays, we do that by phone. So I have students in public health who are volunteering with the health department. So during this lockdown, I would see them in the office. They're on the phone. So what happens is that if there's a positive case of COVID-19, the contact tracing person would talk to them and said, where have you been? Who do you think are your contact? Can you give us the cell phone number of your contacts? And then they will call those number and tell them, you've probably been exposed to somebody with COVID-19, so we'd advise you to come to the health department for testing. If they're test positive, then you ask also their who are their contacts. So because the reproductive rate of COVID-19 virus is 1:3. So one person with COVID-19 can pass it to 3 people. And those 3 people, then each one of those could pass it on the other 3. So exponential increase. You can see that's how fast it's being transmitted. That's why you need to really trace a contact. In other countries, what they have done I think in South Korea or Hong Kong, they've used the cell phone of a person. So by using the cell phone, they can find out where this person had been. For example, recently in South Korea, so somebody went to a nightclub. Right? In South Korea, they've controlled it. And then they have imported case that came from abroad. And this person went to 3 nightclubs. And then they start to see this person tested positive. And then they able to do contact tracing of 3,000 people who went to those 3 clubs. And out of those 3,000 that they tested, 85 were positive. Imagine from 1 positive case, it led to 85 other cases. So nowadays, it's easier to do contact tracing. You can call their cell phone. You can look at their cell phone entry. You can look at their credit card use. You can do a lot of things nowadays that you can, and also you ask them to self-quarantine, and then there's an app already developed to show that if you develop X, Y, and Z symptom, you need to contact the health department or go to the ER because you might be progressing to a severe condition. So nowadays we use the technology and do the contact tracing.
Thank you, Dr. C. That winds up our medical component of the COVID-19 series. And we'd like to thank Dr. C for such a wonderful presentation. Let's give Dr. C a big round of applause. Thank you so much, sir. Thank you. Salamat po.
Thank you.
Carol, I'm sharing.
Yes, May, you can share.
Okay. Okay. The next speaker, this is the time where we kick off our shoes, take off our jacket if you're wearing one, get your drink, and unwind. This is for you. This segment is for you. So I'd like to introduce April Frazier-Wong, BSMS. She's going to do the healing practice for nurses. And she is part of the inaugural cohort of the Spirituality Mind-Body Institute from Columbia University, where she received her master's degree in spirituality and mindfulness in 2016. She also has MS Education at Fordham University and BS International Relations, Community Development, and Educational Studies from Mount Holyoke College. So let's welcome April.
Thank you. Thank you all so much. I'm blessed and happy to be here supporting you all. So much of what was already shared connects to the practices that I will be inviting us into today. So many components of the disease that Dr. C was sharing with us, the physical components, also connects to what I'm hoping to support with, which are the emotional and mental piece of this as well, which is who's healing and who's taking care of you all and the caregivers during this uncertain, highly stressful time. And there's so many components of the virus that speaks to the mental piece of this as well. For example, Dr. C was sharing that these are very uncertain times and a lot of this is very unknown. And the way that the mind works is when things are unknown, the mind will fill in those gaps with a lot of anxiety and stressful narratives to try to fill it in. So we're working with a lot of stress right now. Ourselves and other people are on high alert, just trying to figure things out, and it feels very unsteady. Another thing that Dr. C was mentioning was this idea of being asymptomatic and spreading quickly, this infection. And stress, if you think about it, and anxiety works in a very, very similar way as people. So when we're in a situation of crisis, when we're in a situation of being of service to other people, we're just doing the next best action and taking care of others. Yet little do we know that we are taking in the stress and anxiety maybe of those that we're helping, but we just keep on going through it. And then maybe we get back home and we collapse. There's been lots of things coming out recently around the worry of PTSD around healthcare workers right now because of how uncertain things feel and how much is being asked. So there's this idea as well as like, we may not even know how much stress we're taking in and how that's coming out in our relationships, not just at work, but with our families, with our children, with our partners. But that is spreading as well, the stress and the anxiety in the world. And then this idea, when I think of like mindfulness and self-care and the practices I'll be supporting you all with, we are, as a world, hoping right now, like Dr. C was saying, to flatten the curve. And I like to think of the practices of mindfulness, stretching, and body awareness as us choosing to do that. When we notice our emotional stress and temperature is getting to that high point, when we feel like maybe we're going to collapse, when we feel really stressed out and exhausted, how do we look within ourselves and have tools to flatten our internal curve so we can operate more in a more healthy way with ourselves and with each other? Okay. And then this idea of not being in control, well, we don't know when that's going to change. But what is in our control, what all of us do have right here, right now, is we are breathing and we are in this body. So there are practices that you can engage with any moment that can help just calm down the nervous system, one moment at a time, okay? And so I will engage us in a couple of these today, and then moving on through the series. So let me take care of you, because you're always taking care of other people, right? The first step is see if you can find like a comfortable space. All right, if you're not already in a comfortable space, you know, find a comfortable space for you. Maybe you dim the lights down a little bit. I'll light a candle for you, why not? Yeah, set up your space in a nice calm way. And let this 10 minutes be a pause for you. This is you flattening your own emotional curve inside of yourself, your stress level. Now, when we're in a state of uncertainty, there's a tendency to get disassociated. Not even feeling like, there's been a lot of questions of, what day is it really? Like, people don't even know what day it is. So we're gonna start by just orienting ourselves with the space that you are in right now. So what that is you just take a moment, allow the neck to be really, really soft and loose, and just look with soft eyes at the details around the room that you're in. Yes, and a couple of key things here. Allow the neck, invite the neck to be really, really loose, because when your neck is rigid, it sends a message to your mind that you're like fearful or like looking for a threat in the environment. And then let the eyelids, invite the eyelids to be kind of soft and heavy. We've been looking at lots of screens recently, and that can bring panic into the eyes. So let the eyelids be heavy and just like look around the room that you're in. Notice the shapes, the details, the colors, maybe something that you haven't noticed before that's in the room that you're in. Good. And then if you feel comfortable, you can close down the eyes, and you can totally feel free to turn your video off as well if that makes you feel more comfortable in this space so you can really get into your practice. But allow the eyes to softly close. And see, just with curiosity, what sounds you notice happening right now, but like really, really far away, outside of whatever room you're in. And that's probably different for each of us because we're calling in from different spaces and places. But notice that to hear sounds happening really far away, the body kind of needs to become pretty still and quiet. Good. Yes. And now notice any sounds happening closer to you, like in the room you're in, with curiosity. To the right of you, to the left, in front of you, and behind you. Good. Just noticing. And then start to draw your awareness inside of yourself. So much of what we've been learning about is around respiration, breathing. So why not take a moment and just notice, without changing anything, where you feel your breath the most right now. Because that's good information for you. It's information. Maybe you notice your breath more in the chest or in the belly. Now, if you notice you're breathing in more in your chest area, that's more of like a fear, anxiety response. Like think of when you watch a scary movie, you go, that's in the chest. No problem. If you notice that your breath is more there, see if you can invite the breath lower down, like right by your belly button. It's diaphragmatic breathing. If that feels very weird for you, you can place both hands on your belly if you like to ground yourself there. Good. Now notice just the natural pattern of how you're breathing right now. It's like, wow, like when's the last time I just took a breath and noticed it? Each time you pay attention to your breath, you are fully present in the moment. Notice if the inhales or the exhales, like if one's longer than the other. And we're just going to balance our breathing together here. Dr. C said it so beautifully, like even though we are apart, we are in this together. And interestingly enough, when we start to breathe at the same rhythm, our hearts will start to kind of beat at the same pace too. So we're building a similar breath and heartbeat because we are in this together. Yes, we are in this together. So exhale the air out. You inhale for a count of 3, 2, 1. Exhale, 3, 2, 1. Good. Inhale, 3, 2, 1. Exhale, 3, 2, 1. Inhale, 3, 2, 1. Exhale, 3, 2, 1. Inhale, 3, 2, 1. Exhale, 3, 2, 1. Last time. Inhale, 3, 2, 1. Good. Exhale, 3, 2, 1. Good. When you're ready, gently open up the eyes. Very, very nice. And now, stress rises in the body. We'll just take some gentle movements with the body here. So circles. Circles with the body calms down the nervous system. So take some nice neck rolls here. Yes, like the heavier your thoughts have been, the heavier you just allow your head to be. And then you circle it the other way. 5, 4, 3, 2, 1. You come back to center, and then you can circle the shoulders up towards the ears. Exhale the shoulders back and down. Inhale the shoulders forward and up. Exhale the shoulders back and down. Inhale the shoulders forward and up. Exhale the shoulders back and down. Good, reverse it. Inhale the shoulders back and up. Exhale the shoulders forward and down. Inhale the shoulders back and up. Exhale the shoulders forward and down. Last time, inhale the shoulders back and up. Good. Exhale the shoulders forward and down. Beautiful, beautiful. And now coming into a seat where you feel as though you're like sitting with each other right here, right now. And what that really means is a seat where you're really supported by something underneath you. And feel as though we're with one another here. So the heart is facing the screen. Yeah, so like where hearts are facing each other here. Our shoulders are away from our ears, and the crown of the head's lifting towards the sky. And you can just gently close down the eyes again. And we'll just do a nice brief meditation here. Yes. Positive affirmations. Now, if you think of the mind as like a television with different channels that you can choose. You can have like work channel, relationship channel, stress channel. You know, for many of us, meditation and just sitting with our thoughts can feel very overwhelming. So our first step is not necessarily stopping the thinking completely, because that's really hard to do. But it's just choosing a different channel that could help calm us down, that serves us more in this moment. That serves us more in this moment. So as you sit in your seat, you can just silently think to yourself, I do enough, I have enough, I am enough. Ah, feels good. 3 more times. I do enough, I have enough, I am enough. 2 more. I do enough, I have enough, I am enough. Last one. I do enough, I have enough, I am enough. Good. You can gently open the eyes. And I'd like to seal our practice with that intention again that Dr. C said. We are still in this together. So press the thumbs into the index fingers, the thumbs into the middle fingers, the thumbs into the ring fingers, the thumbs into the pinkies. Again, the thumbs into the index, the middle fingers, ring fingers, pinkies, and just think to yourself, we are still here. We are still here. We are still here. Good. You could reach the arms out wide. Feel free to give yourself a nice pat on the back. hug yourself here. Good. Yes. Thank you all so much. There's this beautiful phrase. I did some teaching in South Africa, and it applies. This proverb applies to our work right now, and it's called Ubuntu. I don't know if you have heard of it, but Ubuntu is this proverb in South Africa where they say, "I am because you are." Yes, someone knows it enthusiastically. I am because you are. My humanity is tied to yours. And I feel like as nurses, it comes very naturally, this idea of I will act from a place of love for other people. And that is how my humanity is tied to yours. But can we take it an even deeper step and think to ourselves, caring for ourselves as caregivers is in fact more deeply caring for the world. And that is what I hope to offer for this series. Next time that we're together, I'll be guiding us through some like body scanning work. It will be a little bit of a longer practice. So if you have any pillows, comfy clothes, lavender oils and things like that, I will invite that in definitely for next week. But I also wanted to leave some time for questions as well, if you all had any.
Yeah, we have a nurse, but they cover by
Good. This lady's good.
Good.
Yeah.
So good. Okay, I think we're all right. You're welcome.
No, we have.
April, I think she left. PNAA, our next module is next Saturday at 7 o'clock. And please join us then. We will send the link to everybody. Apparently, there's a lot of lost people out there who could not join us. So we will send the link to everybody. Thank you so much. See you next.
Actually, can I say something?
Who's this?
The times on the invite were wrong. It's saying 4 o'clock. I signed in early, and so I was able to catch it, but the times were different, it seems like.
Yeah, the only one that is different is today. It's all 7 p.m., but Dr. C was not available for that time slot, so we moved.
Okay.
We moved it up according to his schedule.
Okay. And how do we do the survey?
What survey?
I thought there was a survey on here as well.
The evaluation.
Evaluation.
Yes.
If you registered at mypna.org, you will get an email with the heading PNAA support. That is
okay, great.
To the evaluation.
Okay, I registered, so I'll look for it. Thank you so much. It
okay. So we'll see everybody next Saturday. Thank you.
Thank you.
Ate May?
Yes.
This Virgie, is it different link for next week? Or
same. The same link. Yeah,
same. Thank you so much. Okay.
Yeah, because the link was embedded in the registration, but apparently when after they registered, they did not remember to keep the link or put the link somewhere where they could access it. So a lot of people were lost.
Yeah.
I'll talk to Jonathan and Carol about what we're gonna do for next time so people are not lost.
Okay.
Somebody is asking, they could not register. We closed today, but we open tomorrow morning. So tomorrow you can register again.
Thank you. Have a good weekend.
We just wanted to capture everybody so we could send everything to digital for the evaluation. Thank you so much, everybody. See you next Saturday.
Thank you.
See ya.
See you. Thank you.
Hi, Reno.
Hi, how are you? Thanks, everyone.
Thank you,
Thank
everybody.
Filipino.
Have a nice weekend. Be safe.
Hi, Erlinda.
Hi. See you